What do you think we're looking at over here? This is actually an umbilical cord. This is an umbilical artery, and this is a disorder. And we begin the section on genetic disorders. This is a happy face. What do you think we're looking at over here? This is actually an umbilical cord. This is an umbilical artery, and this is an umbilical vein. This is not so happy a face. This is also a cross-section through the umbilical cord, umbilical artery, umbilical vein is the biggest one, of course, and that's not a happy face. All right, indications for genetic counseling. A 37-year-old, gravida 5, para 0, AB4, comes for prenatal care at 7 weeks gestation. Now, gravida 5 means that she's in her 5th pregnancy. Para 0 means that none of these pregnancies have gone past 20 weeks, and AB4 means that she has lost 4 of these prior to 20 weeks. She's had a very poor reproductive history. 4 previous spontaneous first trimester abortions. She is concerned regarding the likelihood of her next pregnancy being successful. Now, what are her risks here? Number 1, she is called advanced maternal age. She is over age 35. So that's going to be one indication for genetic counseling. And 2 is she's got a poor reproductive history with many spontaneous first trimester losses. When we look at the risk of chromosomal anomalies by maternal age, and remember, the most common reason for first trimester losses is chromosomal anomalies, notice the age and the total risk. At age 20, Down syndrome risk is 1 in 1,500. Total risk of aneuploidy is 1 in 500. Notice what happens with advancing maternal age. The risk of Down syndrome, which is the most common aneuploidy at term, and the total risk goes up significantly. At age 49, 1 in 12 will be Down syndrome, and 1 in 7 is the total risk of aneuploidy. Is that high? Now, if you went to Las Vegas and the likelihood of you winning was 11 out of 12, you'd say that's a pretty good risk. So it's kind of like looking at the glass, is it half empty or is it half full? But still, a risk of 1 in 12 and 1 in 7 is markedly increased over what it is at age 20. And this brings out the important fact that the lowest risk of maternal mortality, of chromosomal anomalies, of reproductive losses, of perinatal mortality is age 18 to 24. The ideal age for childbearing, biologically, not necessarily mentally, not necessarily emotionally, not necessarily socially, is age 18 to 24. At age 35, the risk of total aneuploidy is about 1 in 200, which is about the risk of pregnancy loss with amniocentesis. And so we say age 35 or greater, we offer amniocentesis to women. The most common cause of aneuploidy with advancing maternal age is non-dis. We say age 35 or greater, we offer amniocentesis to women. The most common cause of aneuploidy with advancing maternal age is non-disjunction. And this shows what happens with non-disjunction. The primary gonadocyte gets...
Hey bro, what's up? You know what happened yesterday? I took coffee yesterday. I drank coffee. Yeah, I drank the coffee that I drank yesterday. It didn't let me sleep. I was so tired. I wanted to sleep so bad, but I couldn't. So I kept awake for till like 7 a.m. and I couldn't sleep. And I couldn't do anything productive. I just couldn't focus. And even when I slept 7 a.m., I kept waking up till like 3 p.m. Like sleeping a little bit and waking up a little bit, sleeping a little bit, waking up a little bit. So my sleep schedule is screwed. And I just woke up, like, I felt better now at 6 p.m. So I got some energy drinks so that I can focus. It was so bad, like, I should have drank that coffee.
of each pair of chromosomes, and they are lost in the polar body, which leaves the oocyte with 23 chromosomes. Along comes the sperm, and it has 23 chromosomes. Those two together result in 46 chromosomes, and we have a diploidy. You and I, hopefully, are diploidy, normal chromosomes. If you have loss of the polar body chromosome, it stays with the oocyte, and then you've got the fertilization which occurs. Now you have an extra chromosome, and that is your trisomy. This is increased with advancing maternal age, and we call this non-disjunction. When we look at the indications for genetic counseling, there are numerous.
You might think that you're not forget about stimulation. It's about well-being. So if you're addicted to coffee and you didn't get your coffee, you're gonna feel depressed. You could feel depressed, literally. You could feel very anxious. You could feel like you have a lot of problems, even though you don't have a lot of problems. I had this feeling, and then I realized, oh, I was fasting. I couldn't get coffee, so that happened in Ramadan. Do you recommend it on exam day? If you're addicted, yeah, of course. Will you please do Amber's question, please? I have to finish Kaplan first. Yeah, because I don't have any subscription for Amboss Step 2. So I'll finish Kaplan questions and then do purchase the Amboss one. But I'm very weak at OB-GYN, that's why I'm watching these videos.
These is increased with advancing maternal age, and we call this non-disjunction. When we look at the indications for genetic counseling, there are numerous, and these are in your notes: a previous child with malformations, a previous child with aneuploidy, pregnancy or fetal losses, positive family history of diseases passed from parents to children, a variety of different things, but clearly the most common one is advanced maternal age. And we're seeing more and more women who are deferring childbearing because of career concerns. Now here's a couple who came to see me, and when I first saw them, I thought that this was her father. In fact, he is the FOB, which is father of the baby, and she is the mother of the baby. Advanced.
Yeah, well, I will keep studying today till I die, actually. I have to finish 100 questions today, so yeah, I will.
Paternal age. Now, advanced maternal age is associated with increased risk of non-disjunction. Advanced paternal age is associated with increased risk of new mutations. This is unbelievable. A woman aged 63, a California resident, gave birth at 63 years of age. She spent $50,000 on IVF treatments, and she lied about her age when she went in. But can you imagine age 63? And
you said what are the indications?
Child. When we look at the indications for genetic counseling, there are numerous, and these are in your notes: a previous child with malformations, a previous child with aneuploidy, pregnancy or fetal losses, positive family history of diseases passed from parents to children, a variety of different things, but clearly the most common one is advanced maternal age. And we're seeing more and more women who are deferring childbearing because of career concerns. Now here's a couple who came to see me.
I just have 2 videos left for chapter 1. There's like 18 chapters for OB. told me last night that you don't use books, so how you like keep on with the material in terms of memorizing? That's a good question. I don't look at the information as like chapters. I look at them as pieces of information. So I have a good memory when it comes to long-term memory. So if I understand something very well, it's very unlikely I'm gonna forget it. So back to your question, if I want to review it, I'll just rewatch the video, for it. Like just open the video that has the information in it and just rewatch it. I don't like to read. So yeah.
All right, let's look at the various kinds of chromosomal problems that we can have. Aneuploidy is a term that I've used many times. Let's just define it. Aneuploidy is any time when the numeric chromosomal abnormalities where the cells do not contain two complete sets of 23 chromosomes. It may be fewer chromosomes, it may be more chromosomes, it may be rearrangements. That is a generic term, aneuploidy. I want to just show you what you should look for on the exam if you are given a karyotype. The karyotype is going to be expressed in the chromosomes being laid out in 4 lines. The first line here is the large autosomes. You will almost never find an abnormality here, because if you have a missing large autosome or an extra large autosome, you're going to have so early an embryonic loss that you will probably never even see an embryo or a fetus. That's also going to be true with the second line, which is your medium-sized autosomes. Then we get our small chromosomes, which are the third line and the fourth line, and over here we have our sex chromosomes. Now, which is going to be the most common that you can expect on the exam? The most common aneuploidies are trisomy 13, trisomy 18, trisomy 21, and your sex chromosomes. Now, why don't we see a trisomy 19? I don't have any good explanation for that. I don't know why, but if you would remember 13, 18, 21, and the sex chromosomes. Now, another kind of aneuploidy is polyploidy. Polyploidy is a numeric chromosomal abnormality in which cells contain complete sets of extra chromosomes, not an extra single chromosome, but an extra set of chromosomes. And here we can see, instead of having 46 chromosomes, we have 69 chromosomes. This is called triploidy, 3, 3, 3. They are all extra set of chromosomes. This occurs when you have a dispermic fertilization of a normal egg, and you have 3 pronuclei, and the most common genetic makeup is a 69XXY. Now, this is what you would see with an incomplete mole. A complete mole is 46XX, and those X's are paternally derived. Incomplete mole is 69XXY. This is an image of a triploidy fetus. Notice how huge the placenta is, and this is a fetus that did not survive. This is basically a lethal anomaly. This is a patient of mine who gave birth to a triploidy baby. Now, what do you think we found prenatally? Marked growth restriction, intrauterine growth restriction, significant. And one of the things that you will find that causes severe intrauterine growth restriction is aneuploidy, early first trimester infections, gross anomalies. Interestingly, when this child was born, you know what the parents' comment were? Isn't she beautiful? Do you think this is a beautiful fetus? What the parents see and what we see are quite different. The most common aneuploidies that we see, the most common trisomy is 47 XXY plus 21. This is a genetic shorthand, an extra single chromosome. The most common trisomy is Down syndrome. The most common monosomy, and monosomy
Turner.
is where we have a missing single chromosome, is 45X, also known as Turner syndrome. The most common polyploidy, and polyploidy is an extra set of chromosomes, is your 69XXY, and we just saw the picture of that. Another kind of aneuploidy is mosaicism. This is where you have two or more cytogenetically distinct cell lines in the same individual. Let me show you a picture. A picture is worth 1,000 words. A normal female in every cell of her body has 46XX. A mosaic woman may have both 46XX and 45X. So some of her chromosomes are 46XX, and some of them are 45X. This is called a Turner's mosaic. What is the significance of mosaicism? You can see there are various kinds of mosaicism. There can be 2 or even 3 cell lines. And when you have a Y chromosome particularly, that's not good. What happens when you have multiple cell lines? The effect on the ovarian follicle is premature ovarian failure. And when you see ovarian failure or menopause, which occurs prior to age 30, one of the things you need to think about is a mosaic chromosome pattern. The other thing is, if you've got mosaicism in the ovaries, cancer can develop in the form of gonadoblastoma. Now, this is not very common. There have only been about 200 to 300 cases reported, but those chromosomes can result in cancer, and those ovaries need to be removed. All right, let's look at some specifics in terms of pregnancy losses. We'll look at Turner syndrome, Klinefelter's, Down syndrome, Edwards syndrome, and Patau. And you'll notice we don't, at least if you're going to be politically correct, you don't say Turner's syndrome, it is Turner syndrome. For some reason or other, they've taken away the S. Let's look at the effect of aneuploidy and maternal age. And this is looking at pregnancy loss or miscarriage by maternal age. You can see that up to age 35, there's not a whole lot of change. But after age 35, the rate of miscarriage or spontaneous pregnancy loss goes up significantly. I mean, after age 40, it's almost 40%. So what we know is with advancing maternal age, the likelihood of pregnancy loss goes up significantly. This is an article from the New England Journal of Medicine, How Old is Too Old for AMA. And this is the figure that was shown. And we're going to look at the likelihood of fertility and the likelihood of spontaneous pregnancy loss as a function of maternal age. And you can see that with advancing maternal age, fertility declines and the risk of pregnancy loss goes up. You can see that spontaneous abortion goes up significantly after age 35, and you can see that after age 20 to 24, there is a progressive decline in fertility. Again, the ideal biological age for childbearing is age 20 to 24, 18 to 24. All right, let's look at some specific syndromes. Turner syndrome, 45X, 1 in 10,000. I might say that probably one of the most common aneuploidies, if you would do karyotyping of early pregnancy losses, is Turner syndrome. It is one of the most common ones. Now, at term, the most common aneuploidy is trisomy 21. But if you would do karyotyping of early pregnancy losses, Turner syndrome, 9 common ones. Now, at term, the most common aneuploidy is trisomy 21. But if you would do karyotyping of early pregnancy losses, Turner syndrome, 98% of Turner syndrome conceptions are spontaneously aborted. Wow. And here we have Turner syndrome. Well, I should have taken out the S over here. It is the loss of the paternal X chromosome. Now that would be worth remembering for the exam. Loss of the paternal X chromosome, and you can see there's only one X chromosome here. Here we have a 17-year-old who has gonadal dysgenesis or Turner syndrome. What I want to point out is this is her height, 1 foot, 2 foot, 3 foot, 4 foot. She is basically about 4'8". Short stature. And short stature is...
You're welcome, bro. I also enjoyed our conversations. I'm gonna do it again.
Seen with many of the aneuploidies, with one exception, and that is Klinefelter syndrome. Klinefelter syndrome. Notice her body morphology. While she is 17, she has a phenotype of what age female? About an 8 or a 9-year-old. Absence of secondary characteristics. Why is there no secondary sex characteristics? Because there are no follicles in the ovaries. Notice the increased skin fold thickness here. One of the anatomic things we look for on ultrasound is increased nuchal skin fold thickness. The lymphedema that you see is very common in Turner syndrome. You can see the edema of the hand. You can see edema of the foot. Another finding that we will see is coarctation of the aorta, a narrowing of the aorta. And this one happens to be a postductal and is in the descending aorta. Here, it's hidden by the pulmonary artery. Also over here, it is hidden. This increased lymphatic flow, or I should say failure of drainage of the lymphatics, it results in a cystic hygroma. This is an ultrasound, and this is a transverse section through the neck. This is the neck right here, the spine, and here you can see the septations of the cystic hygroma. Here's another one. And when you see these cystic hygromas early in pregnancy, it is almost always lethal and often is associated with Turner syndrome 45X. Here we have Turner syndrome, and you can see the web neck. The web neck is the residual of the cystic hygroma, which has shrunk, and the loose skin is left in the form of a web neck. This shows the significant cystic hygroma and the hydropic changes of this fetus that had Turner syndrome. You can see this fan shape of the cystic hygroma on this total body x-ray. And we'll talk about this later on, that when you have a fetal death, one of the helpful findings is to take a total body x-ray. I'd also like to point out what we call bell-shaped chest, the pulmonary hypoplasia, which results. This is a artist.
So what is the cystic hygroma? Is it a growth like lymphedema? Is that it? Lymphangioma. Sac-like structure with a thin wall that most commonly occur in the back of the head and neck. Okay, just a growth of the lymph vessels.
And the pelvic organs of a Turner syndrome, and you notice this is the streak gonads. There is no follicles in the ovary. So what do you think this woman's FSH is going to be? Because there is no feedback from the estrogen, she's going to have very high levels of FSH, which is consistent with ovarian follicular failure. Interestingly enough, patients with Turner syndrome, even though they have high levels of FSH, do not have hot flashes. And I'm not entirely clear why that's the case. Another very frequent early pregnancy aneuploidy is trisomy 16. So when we look at early pregnancy losses, it is Turner syndrome and trisomy 16. Another specific syndrome is Klinefelter syndrome. This is 47XXY, occurs 1 in 2,000 births. And this is a aneuploidy which has no ultrasound markers which are found prenatally. So most Klinefelters are not diagnosed prenatally. You'll notice on the karyotype, we have 2 X's and a Y. So we have an extra X chromosome, Klinefelter syndrome. What should you know for the board exam? Notice the tall stature. This is unique because most of the other aneuploiders are associated with short stature, with exception of Klinefelter syndrome. Notice the centripetal obesity, the increase in the adiposity around the waist, and notice the small genitals, micropenis and small testicles. These are most likely going to be infertile. They also have a long arm span, which is found. Down syndrome is a common aneuploidy. 1 in 800 is the most common one seen at term. Interestingly, Down syndrome is named after John Langdon Down, who described the syndrome in 1866. But it wasn't until almost 100 years later that it was realized that this was a chromosomal problem. This is your typical picture of Down syndrome with the protruding tongue. What I'd like you to remember for the board exam is associated with endocardial cushion defects and duodenal atresia. This is the endocardial cushion defect. Here we have the pulmonary artery over here. This is the aorta. And what we've got here is the interventricular septum. If you have an endocardial cushion defect or atrioventricular canal defect, notice what happens to your interventricular septum. It's gone. And what you have then is basically a single atrium, a single ventricle, and frequently a single valve. If you have over here, this is the aortic duodenal atresia. This is the endocardial cushion defect. Here we have the pulmonary artery over here. This is the aorta. And what we've got here is the interventricular septum. If you have an endocardial cushion defect or atrioventricular canal defect, notice what happens to your intraventricular septum. It's gone. And what you have then is basically a single atrium, a single ventricle, and frequently a single valve. You can have atrial septal defects. You can have ventricular septal defects. If it's marked, we have atrioventricular canal defect. So 50% of Down syndrome babies will have AV canals. And if you have on ultrasound, the finding of an AV canal, 50% of those babies will have Down syndrome. So that is clearly an anatomic marker. This is another marker, a double bubble. What is the double bubble? The double bubble is from enlargement of the proximal duodenum and of the stomach. I want you to notice this black, let's go back, this black stuff here. What is this black stuff? This is polyhydramnios, excessive amniotic fluid. When you have upper GI obstruction in the fetus, you're going to have polyhydramnios. Here's another case, and you can see the double bubble here, and notice how much amniotic fluid. Duodenal atresia is associated with Down syndrome, is associated with polyhydramnios. There are lots of other markers which are not worth going into right now for Down syndrome. But if you'd remember, double bubble, trisomy 21. There are lots of other markers, as we said. This is an interesting one. Brush field spots are the ring of white pigmentation around the iris here. You see this here? Brush field spots associated with Down syndrome. Now this is in your notes, and this figure shows what is the risk of Down syndrome as a function of maternal age. And there are two curves. There is the black curve here, and there is the red curve, which goes over here. If you look at the age of mothers of babies who have Down syndrome, it's going to be the red curve. If you look at the age-specific risk of Down syndrome, it's going to be the black curve. Now, if you look at the black curve, what maternal age is the lowest risk of Down syndrome? Age 20 to 24. Again, biologically, that's the optimal time. You can see it as a J-shaped curve. It goes higher when you have a young woman, and it goes up when you have a woman who is past 20 to 24. However, if you look at the age of women who have babies with Down syndrome, you notice most of them are going to be between 20 and 30. Now, how does this fit? Well, most women who have babies are between 20 and 30. Even though their age-specific risk is lowest because they have more babies, if you look at Down syndrome children and the age of the mothers, they're more likely going to be less than age 30. And the bottom line of this point is that if we screen for Down syndrome by only looking at women over age 35, we're going to miss a lot of Down syndrome babies. This looks at the risk of Down syndrome as a function of maternal age, and you can see there is an increase as we get past age 20 to 30. Now, where does the risk significantly go up? It goes up here, it goes up here. It's probably after age 40 that it goes up significantly. And we arbitrarily in the United States say at age 35, we call this AMA. In other countries, like in British Columbia, Canada, the age at which genetic amniocentesis is offered is age 38. And this is not a medical decision. This becomes a cost effectiveness. How much money do we want to spend to have a pickup rate of whatever? And again, remember the most common cause of trisomy 21 is non-disjunction. And what causes that is probably the exposure of the follicles in the ovaries of these women to cosmic radiation, which is always with us, the nuclear power plants, which can give you radiation, a lot of different things. This is called fluorescent in situ hybridization. This is a genetic test of the follicles. The common cause of trisomy 21 is non-disjunction. And what causes that is probably the exposure of the follicles in the ovaries of these women to cosmic radiation, which is always with us, the nuclear power plants, which can give you radiation, a lot of different things. This is called fluorescent in situ hybridization. This is a genetic test which can look for aneuploidy. This is using a fluorescent DNA probe looking at specific chromosomes. And this is used to identify if there is an extra trisomy 13, 18, 21, and the sex chromosomes. And this particular picture, you can see that we have a pink to identify chromosome 21. We have a green fluorescence to identify chromosome 13. We have 2, which is normal number of 13 chromosomes, but we have 3 21. This is a rapid test that can be done very quickly. If you're going to do the typical cell culture and then karyotyping with banding, it's going to take 7 to 10 days. If you want to have a rapid turnaround, fluorescent in situ hybridization or FISH can be done quickly. Here again, you can see the fluorescent in situ hybridization, which looks at chromosomal rearrangements. This is looking at the simian crease, which is not found in all Down syndrome, but at 53%. 1 to 2% of normal people will have this over here. And here we have a simian crease in an intelligent physician who just happens to have the simian crease. But it is found more commonly with Down syndrome. Okay, Edwards syndrome, this is trisomy 18, you can see is far less common than trisomy 21. 1 in 8,000 live births. And here we have the karyotype, and you can see the 18 chromosome. There are 3 of this. Risk factor, advanced maternal age. We'll talk about this later on when we're doing the screening for Down syndrome, when we're looking at the triple marker screen and the quadruple screen. This is a fetus that I took care of in utero of a woman who was advanced maternal age and had a trisomy 18. What I want you to notice here for board exam, look at the bottom of this foot. This is what we call a rocker bottom foot. It's not seen in all trisomy 18, but you can see it here very clearly. This was a fetal death, and that's why the skin looks so abnormal here. This is an ultrasound image, and this is of a fetus, and you can see again the rocker bottom foot. This is a 3D ultrasound, which shows the rocker bottom foot of trisomy 18. Another thing that you'll see with the trisomy 18 is a clenched fist. This is the same fetus that I showed you before. What I love to see on ultrasound is where the fetus opens up its fingers. Now, it doesn't guarantee that it doesn't have aneuploidy, but if I see the fingers always clenched like this, I'm concerned, could we have a trisomy 18? And here you can see a 3D ultrasound of the clenched fist with trisomy 18. Here's the nose, here's the mouth. The clenched fist. Again, it's not seen with all, but it is seen with 40%. Trisomy 13, again, not very common, 1 in 6,000 live births, profound mental retardation, and for all intents and purposes, this is a lethal condition. There are some unusual findings that we will see with this. Here is our 3 chromosomes with the trisomy 13. Again, risk factor is AMA. Condition 13, again, not very common. This is fetal maternal screen and the quadruple screen. This, later on, the 18 chromosome, there are 3 of this. Risk factor, advanced maternal age. We'll talk about this later on when we're doing the screening for Down syndrome, when we're looking at the triple marker screen and the quadruple screen. This is a fetus that I took care of in utero of a woman who was advanced maternal age and had a trisomy 18. What I want you to notice here for board exam, look at the bottom of this foot. And you can see again the rocker bottom. Another thing that you'll see with the trisomy 18 is it opens up its fingers. Now, it doesn't guarantee that it doesn't have aneuploidy, but if I see the fingers always clenched like this, I'm concerned, could we have a trisomy 18? And here you can see a 3D ultrasound of the clenched fist with trisomy 18. Here's the nose, here's the mouth, the clenched fist. Again, it's not seen with all, but it is seen with 40%. Trisomy 13, again, not very common, 1 in 6,000 live births, profound mental retardation, and for all intents and purposes, this is a lethal condition. There are some unusual findings that we will see with this. Here is our 3 chromosomes with the trisomy 13. Again, risk factor is AMA. Trisomy 18 can be screened for using the triple marker screen. There is no good screening for trisomy 13. You will see major anatomic abnormalities, cleft lip and palate. Now, this is a bilateral cleft lip and palate. Now, not all babies with cleft lip and palate are going to have trisomy, but you'll see particularly severe forms with trisomy 13. Another thing that you'll find is a single eye, known as cyclops, and there is a soft tissue protuberance above the single eye called a proboscis. Cyclops, proboscis. This is a patient that I had. This is a two-dimensional ultrasound, and you can see here babies with cleft lip and palate are going to have trisomy, but you'll see particularly severe forms with trisomy 13. Another thing that you'll find is a single eye, known as cyclops, and there is a soft tissue protuberance above the single eye called a proboscis. Cyclops, proboscis. This is a patient that I had. This is a two-dimensional ultrasound, and you can see here the single eye, the cyclops, and this is a protruding proboscis, which is above the single eye. Here's the ultrasound of the proboscis as it is extending out of the head. Another finding with trisomy 13 is holoprosencephaly. Here we have the fused thalami. You notice there is no midline falx, and basically there is absence of cerebral tissue, a major anatomic anomaly. And whenever I see holoprosencephaly, I want to do an amniocentesis looking for aneuploidy. This is a MRI of a newborn with holoprosencephaly, and you can see there is a thin cortical mantle here with basically no cortical tissue. Holoprosencephaly found in 40% of trisomy 13s. Let's a single eye. Here's the ultrasound of the here we have the fused thalami. You notice there is no midline falx, and basically there is absence of cerebral tissue, a major anatomic anomaly. And whenever I see holoprosencephaly, I want to do an amniocentesis looking for aneuploidy. This is a MRI of a newborn with holoprosencephaly, and you can see there is a thin cortical mantle here with basically no cortical tissue. Holoprosencephaly found in 40% of trisomy 13s. Let's look at the summary now of genetic syndromes. What this table looks at is the kind of genetic problem, this is the name of the syndrome, and stature, IQ, and unique findings, which you may find on the Step 2 USMLE exam. Let's start with Klinefelter syndrome, 47XXY, we talked about that. And this is unique in that it is tall stature. Often there is a decreased IQ, although it is not profound. What you should know for the board exam is microgenitals and infertility. The other syndromes, Turner, Down, Edwards, and Patau, all have short stature. And when we look at IUGR, intrauterine growth restriction, one of the causes of IUGR, particularly symmetrical IUGR, is aneuploidy. And we have Turner's Down syndrome, Edwards, Patau, all of these have short stature. Turner's has normal IQ, but the others have mental retardation to varying degrees. The unique findings for the exam, if you see a case with a web neck or coarctation, you should think Turner syndrome. If you see duodenal atresia or endocardial cushion defects of the heart, you should think Down syndrome. Abnormal feet, rocker bottom foot, and the clenched fist, think Edwards syndrome, trisomy 18. And if you have a fetus with holoprosencephaly or cyclops, you should certainly think of Patau syndrome, trisomy 13. All right, let's look at the various kinds of chromosomal problems. Now let's move to case is sickle cell disease, SS. It's affected by each if they're no, it does is they knew. Now let's move to. This is a stamp from Austria, which is honoring the 100th anniversary of Gregor Mendel, the discoverer of the laws of inheritance. he was an Austrian monk. He studied sweet peas, and he studied 10,000 plants, 22 varieties of peas, and he wrote a paper that was unrecognized for 35 years after his death. He came up with the laws governing Mendelian genetics. Let's look at that. This is our case. By the way, I wrote these cases trying to incorporate the key features of these topics that you may see on the exam. So I think it's well worth your time to examine these cases in detail. We have a 23-year-old black prima gravida who was 12 weeks gestation, first trimester. She's been diagnosed with sickle cell trait. Sickle cell trait has hemoglobin A and hemoglobin S. Her husband and father of the baby is also AS, or sickle cell trait. What is the risk of her baby having sickle cell disease, SS? Okay, this is in your notes, and it looks at the various pedigrees of the Mendelian disorders. We have autosomal dominant, we have autosomal recessive, X-linked dominant, and this is the X-linked recessive. And we're going to go through each one of these in order. The squares are males, the circles are females. If the circle or square is double autosomal dominant. Autosomal dominant is the most common Mendelian defect, and here we have the pedigree. What should you look for? Number one, does the disorder skip any generations? And the answer is no, it's in every generation. Second question, are there any carrier states with the X's? There are no X's, so it does not. And the kid atomic a triad, three. Are there differences in gender? And you can see the carriers can be both male. Go to multifactorial inheritance. What is of interest inheritance, and now go to multifactorial inheritance. What is of interest is that multifactorial inheritance causes more birth defects than either cytogenetic or Mendelian. Multifactorial, by definition, has many possible causes. The Mendelian is a single gene. Only one gene can cause the problem. With multifactorial, a number of genes can produce the same disorder. An example of this is our case. A 32-year-old woman who has corrected tetralogy of Fallot. So she had a congenital heart defect when she was born, but it was corrected. She is now pregnant at 18 weeks with a male fetus. She inquires as to the chance that her son has congenital heart disease. Is there an inheritance risk with a mom who had heart disease? And the answer is yes. Multifactorial inheritance is also known as polygenic, which means not just a single gene disorder, but many genes can result in the same phenotype. Causes, 70% of birth defects are from multifactorial. So if you're asked on the exam, what's the most common cause of birth defects, the answer is going to be multifactorial or polygenic. The mechanism is the interaction of the genes with the environment, which means that you not only have to have a genetic predisposition, but you also need to have an environmental milieu which will allow it to be manifested. If you look then at the recurrence rate, it's going to be 2 to 3%. Is that high? No, it's not high, but it is not zero. The examples are NTD, neural tube defects, congenital heart disease, cleft lip, and palate. These are all multifactorial. Neural tube defect is one that we're particularly concerned with. Here we have a fairly severe cleft lip and palate. Here's one which is even worse. These are multifactorial in inheritance, and there will be then a recurrence rate of 2 to 3%, depending on the family history. Neural tube defects, and here we see varying forms. This is a spina bifida occulta, this is a meningocele, this is a meningomyelocele. The first organ system to develop is the central nervous system. Of exam purposes, a good question on the exam would be, how many days post-conception do neural tube defects develop? And that's 26 to 28 days post-conception. How many weeks is that in menstrual weeks? 6 weeks. By the time the 6th menstrual week is over, or the 4th post-conception week, the neural tube defects have already done their thing. And when we look at, for instance, type 1, type 2 diabetics who are out of control, neural tube defects is a primary concern in terms of malformations. By the time you see them for the first prenatal visit, it's over. So if you can do prevention of neural tube defects with patients with diabetes, blood sugar control must be started prior to the pregnant birth. That would be how the first tube defect in inherit. These are all multifactorial. Neural tube defect is one that we're particularly concerned with. Here we have a fairly severe cleft lip and palate. Here's one which is even worse. These are multifactorial in inheritance, and there will be then a recurrence rate of 2 to 3%, depending on the family history. Neural tube defects, and here we see varying forms. This is a spina bifida occulta, this is a meningocele, this is a meningomyelocele. The first organ system to develop is the central nervous system. Of exam purposes, a good question on the exam would be, how many days post-conception do neural tube defects develop? And that's 26 to 28 days post-conception. How many weeks is that in menstrual weeks? 6 weeks. By the time the 6th menstrual week is over, or the 4th post-conception week, the neural tube defects have already done their thing. And when we look at, for instance, type 1, type 2 diabetics who are out of control, neural tube defects is a primary concern in terms of malformations. By the time you see them for the first prenatal visit, it's over. So if you can do prevention of neural tube defects with patients with diabetes, blood sugar control must be started prior to the pregnancy. Here we see an ultrasound of a normal fetal spine, and you can see the parallel ossification centers of the spine. Here again, you can see this. This is the iliac wings down here. What do we see here? There's a cystic structure down in the lumbosacral area, and that's the most common site of a spina bifida. Here you can see on ultrasound a normal vertebral column down to here, and then we have the defect, spina bifida. And here we can see the extent of the sac, which is fairly significant. The most common site is in the lumbosacral area. This can result in a obstructive hydrocephalus, and on head ultrasound you will see enlargement of the lateral ventricles here and here. The fourth ventricle, which normally you can't even see, is often enlarged. These children will often require a ventriculoperitoneal shunt in order to relieve the pressure from the cerebrospinal fluid. Here we have the typical location for a spina bifida, down in the lumbosacral area. This one is a little bit higher. This is in the thoracic area. And of course, all of the innervation which occurs below this point may very well be affected, and this child will have loss of bowel and bladder control as well as inability to ambulate. Here we have another spina bifida, and a little bit closer view of that. Here we have a couple of defects, one which is a little higher thoracic, and this is down in the lumbar region. This is where the defect occurs rather than caudally, cranially, and this is now an encephalocele. And this is an in utero MRI showing the brain tissue which is out in the encephalocele sac. And this is a postnatal picture of the same fetus, although after it's born. The prognosis is very poor once you have brain tissue which has gone into the encephalocele. This is probably the most severe form of a neural tube defect, and this is your anencephaly. And you can see above the orbits, basically there's no cranium and no cerebral hemispheres. This is a lethal defect. This picture shows not only a anencephaly, but also a omphalocele. And what this picture is trying to convey is when you see one birth defect, think of a second or even a third, because they tend to go in groups. So if you see one, then you want to look very carefully to see if there are others. Here we have a fairly severe cleft lip and palate, and you can see also a cranial defect as well. They tend to go along together. Now, how can we help prevent this? One of the ways we can prevent neural tube defects is by giving folate, folic acid. And because the neural tube closes so early, by the end of the fourth postconceptional week, if you're going to do anything to help this, you need to start preconception. All women of reproductive age group need to be on at least 0.4 milligrams a day. If they are high risk, they should be on 4 milligrams a day. And women at high risk would fall into 4 categories. One would be a previous baby with neural tube defect. Number 2, a positive family history of neural tube defect. 3 would be over type 1 and type 2 diabetes. And number 4 would be women who are on anticonvulsants, because anticonvulsants will decrease folate absorption. So they need to be on high doses. And I think we don't do a good enough job to get this information out, particularly to young girls who have type 1 diabetes. Now, the Food and Drug Administration requires now that all pasta and bread products be fortified with folic acid to try to reduce the neural tube defects. And this looks at the average number of neural tube defects a year in the United States before folate was required to be supplemented and after it was supplemented. If you just have the regular diet, you will probably get about 0.15 milligrams of folate, but you need 0.4. Will folate supplementation completely eliminate neural tube defects? No, because there is not only an environmental effect, which is low folate, but there's also a genetic contribution. I'm always concerned about the Atkins diet. When you decrease carbohydrate intake, will you also then decrease folate intake, and what will that do in terms of neural tube defects? There is evidence that women who have babies with neural tube defects may have actually autoantibodies against folate receptors, and the high dose, the 4 milligrams, then overrides those antibodies and can protect against it. Remember, folic acid is a water-soluble vitamin. You cannot get toxicity. If you get too much, it'll just come out in the urine. This, I think, is really an important point. Folic acid not only decreases neural tube defects, but it also reduces congenital heart defects, the first real preventive strategy to reduce the risk of congenital heart disease. And when you look at type 1 and type 2 diabetics, they have an increased risk of neural tube defects and congenital heart disease. And both of those can be reduced by, number 1, decreasing the blood sugars into the normal range, and 2 is folic acid supplementation. Family history of neural tube defect and risk category.
It's high yield to know the high risk factors.
One would be a previous baby with neural tube defect.
Previous baby.
Number 2, a positive family history of neural tube defect.
Family history.
3 would be over type 1 and type 2 diabetes.
Type 1, type 2.
And number 4 would be women who are on anticonvulsants, because anticonvulsants will decrease folate absorption.
Anticonvulsants, type 1, type 2, positive family history.
So they need to be on high doses. And I think we don't do a good enough job to get this information out, particularly to young girls who have type 1 diabetes. Now, The Food and Drug Administration requires now that all pasta and bread products be fortified with folic acid to try to reduce the after intake of milligram. So only DD heart is reduced by, number one, decreasing the blood sugars into the normal range, and two is folic acid supplementation. When you look at the percentage of birth defects that come from cytogenetic disorders, such as the trisomies, 1%. Teratogenic, 1%. Mendelian, 15%. This is your autosomal recessive dominant.
No, not the whole. I'm continuing on. I'm continuing what I did yesterday. So I finished this 1, 2, 3, 4, and then I finished this right now. 1, 2, 3, 4. I'll finish chapter 1 and then do chapter 2. But all these are not that high yield. Let's get it, King. Thank you per TZH. Thank you, man. Yeah, but that's not high yield. I know most of it, so I'm probably wasting time right now, but I'm having fun, so whatever.
By far, the majority of birth defects are multifactorial, and those are both genes and environmental influences. All right, that brings to an end genetic disorders. So now go to multifactorial inheritance.
Okay. I'm done with chapter 1. Let's do chapter 2. I'm waiting for the you gotta do questions tonight though. Yeah, I will. I will definitely do questions. I have the Q bank open, but it doesn't it's saying error here. Yeah, see? It's saying error. Do you watch all the videos or only weak points? So, I am very weak in OB-GYN, so that's a big weakness. So I only watch the weakness points. So OB-GYN the entire OB-GYN is a weakness of mine because I didn't attend my medical school lectures and rounds. So I had to to do a med school OB-GYN class right now. With myself, Okay.
All right, this next chapter 2 is entitled Failed Pregnancy.
Okay, this is high yield. This is where questions are asking. How can I get AMBOS step 3? Do they have step 3? Oh, they definitely have step 3. How much is it? Wow, 2,000 questions. Bro, I bet you're actually ready for step 3 right now. Just do your world and get the exam done. It's pass fail, isn't it? Or fail? Is it pass fail? Okay, no, it's scored, I guess. Yeah, it's scored, but it doesn't matter. You're scored in step 3 doesn't really matter. All right, starting from here is very high yield. There's a lot of questions about this.
We're going to look at is induced abortion, spontaneous abortion, fetal demise, and ectopic pregnancy. The first one will be induced abortion. In the United States, 50% of pregnancies are unintended.
Wow.
Not many are really planned. Of those unintended pregnancies, 40% are aborted.
Oh no.
The risk of abortion.
Did you do step 1 in Egypt or in the USA? No, I did it in Buffalo here 2 years ago. Yeah.
Morbidity and mortality increases with advancing gestational age, and we'll look at that in both the first and second trimester. Overall, in the United States, about 1 in 3 pregnancies are terminated by abortion. The maternal
Wow.
mortality associated with childbirth is 12 times higher than with abortion. Most abortions are performed in the first trimester, and the maternal mortality rate is significantly less than if the pregnancy went to term.
Oh, okay. Maternal mortality associated with childbirth is 12 times higher than that with abortion.
Most abortions are performed in the first trimester, and the maternal mortality rate is significantly less than if the pregnancy went to term. There's been a lot of controversy about abortion being associated with increased breast cancer. This has been looked at in many epidemiologic studies, and the evidence, I think, is fairly convincing that there is no relationship between. A recent development in 2000, the Food and Drug Administration approved mifepristone, which used to be called RU486, as a medical termination of first trimester pregnancies. And we're going to look at that in a moment. Here we see a lot of controversy and anger over abortion. And I suspect that that will go on for time immemorial. Everybody has strong feelings one way or the other. This is a patient who came with a gun to an obstetrician gynecologist office because of anger over abortion. All right, the most common first trimester abortion is a surgical procedure which is called the suction D&C. 90% of abortions in the United States are first trimester, and that is done in the first 12 weeks of pregnancy.
Okay, suction D&C. Suction D&C is the most common and is done before 13 weeks. Before 13 weeks. 90% of abortions
are done in an abortion clinic. Prophylactic antibiotics are given to try to minimize the risk of infection. Pain relief is given by either conscious sedation or paracervical block. The cervix is
paracervical block. Okay, so around the cervix. Paracervical block.
tapered metal dilators. I'll show you what that looks like in just a minute. Or osmotic laminaria. Laminaria are sometimes called laminaria japonicum. They are desiccated or dried out sticks of seaweed which are placed in the cervix, and as they absorb the fluid from the cervix and the vagina, they dilate, and as they open up, they will bring up stent. Or osmotic laminaria. Laminaria are sometimes called laminaria japonicum. They are desiccated or dried out sticks of seaweed which are placed in the cervix, and as they absorb the fluid from the cervix and the vagina, they dilate, and as they open up, they will bring about dilation of the cervix as well.
Wow. Osmotic laminaria.
trimester abortions are rare, but include infection, endometritis, retained products of conception. Everything wasn't taken out. These are uncommon. The maternal mortality rate is 1 per 100,000. Now, if you look at the overall maternal mortality in the United States, it is 7 per 100,000 for pregnancies that go to term with a vaginal delivery. So this is significantly less taken out. These
Endometritis, return products of conception.
Are uncommon. The maternal mortality rate is 1 per 100,000. Now, if you look at the overall maternal mortality in the United States, it is 7 per 100,000 for pregnancies that go to term with a vaginal delivery. So this is significantly less than that. This picture shows what a laminaria looks like. It is seaweed which is dried out, and so it has shrunk. This cuff on this end is to prevent...
What does seaweed mean? Seaweed. That doesn't look tasty.
Too far into the cervix, and the string is to enhance the removal of the laminaria. This is how you want to put it in. So it goes through the external os, through the internal os. As it absorbs the fluid, it will dilate and become larger, and so will provide then the dilation needed to put a suction curette into the cervix. This laminaria was put in too far. This one was not put in far enough. Laminaria japonicum. First trimester abortions historically were performed using a sharp curette like this. That is not done anymore. These curettes increase the risk of perforation and complications. The current way that abortions are usually performed is by taking a hollow suction curette, placing it through the dilated cervix, creating a suction with a pump, and then aspirating the uterine contents out. Medical first trimester abortion uses oral mifepristone. The trade name is Mifeprex, used to be called RU486. It is a progesterone antagonist, so it blocks the effect of progesterone, and you recall we talked how important progesterone is to maintaining the pregnancy.
That's Plan B, right? Isn't that Plan B? Oh, that's okay. Levonorgestrel. Okay. Okay, so it's not mifepristone.
The oral misoprostol, the trade name is Cytotec, is prostaglandin E1. And what this does, it brings about
oral mifepristone and oral misoprostol. Oral mifepristone, oral misoprostol.
Of the myometrium. So we have mifepristone, which is a progesterone antagonist and blocks the effect of progesterone, and then misoprostol, which brings about contractions to expel the uterine contents. And they have asked on the exam, what kind of prostaglandin is it? And it is a prostaglandin E1. The FDA, Food and Drug Administration, has restricted the use of mifepristone to the first 63 days of amenorrhea. And the reason for that is that the earlier it is used, the higher the rate of successful abortion. And if you go past the 63 days, the likelihood of failure increases. Using it with the 63-day limitation, most patients will spontaneously pass everything from the uterus. 2% will still require the vacuum curettage, so it's not perfect. First trimester abortion, mifepristone. This is the advertisement for it, the early option pill. This was fought very hard by those who are anti-abortion, because this takes the abortion procedure out of the doctor's office into the patient's home, where nobody needs to know that she's having it done. Mifeprex is the trade name. This map shows the countries of the world where mifepristone has been approved, at least of 2002. You can see in the United States, in most of Europe, in China and in India, in Canada and in Catholic countries, it has not been approved and is not available. The second trimester methods, this will sponsor the early option pill. This was fought very hard by those who are anti-abortion, because this takes the abortion procedure out of the doctor's office into the patient's home, where nobody needs to know that she's having it done. Mifeprex is the trade name. This map shows the countries of the world where mifepristone has been approved, at least of 2002. You can see in the United States, in most of Europe, in China and in India, in Canada and in Catholic countries, it has not been approved and is not available. The second trimester methods, the most common is D&E, which is dilation and evacuation. This is a second trimester procedure. Common is it has not been in the United States.
Okay, oral mifepristone, oral misoprostol, oral mifepristone, oral misoprostol. First 63 days of amenorrhea. First 63 days of amenorrhea. The earlier the pregnancy, the higher the rate of successful abortion. 2% require vacuum curettage.
Was of the doctors very hard by those who are anti-abortion, because this takes the abortion procedure out of the doctor's office into the patient's home, where nobody needs to know that she's having it done. Mifeprex is the trade name. This map shows the countries of the world where mifepristone has been approved, at least of 2002. You can see in the United States, in most of Europe, in China and in India, in Canada and in Catholic countries, it has not been approved and is not available. The second trimester methods, the most common is D&E, which is dilation and evacuation. This is a second trimester procedure.
Okay, wait a second. Isn't the previous one dilation? Suction, D&C, D&E, okay. First one is suction, D&C. Dilation and curettage. D and E is...
Common is D&E, which is dilation and evacuation. This is a second trimester procedure. The cervix is dilated with the osmotic laminaria, and the number of millimeters of dilation should equal the number of weeks gestation. So we're going to have to dilate it more than a first trimester procedure. After 14 weeks, the fetus to remove by aspirating it through a curette, and so the fetus is removed in pieces. This is a gross procedure. You take out the arms, you take out the legs, you take out the head, make sure that all of it is removed. In weeks, the fetus is too large to remove by aspirating it through a curette, and so the fetus is removed in pieces. This is a gross procedure. You take out the arms, you take out the legs, you take out the head, make sure that all of it is removed. If it is done...
You remind me of Med School Bro, that guy on TikTok. Yeah, I know that guy. How are we similar, bro? Like, he's an Australian dude.
Under ultrasound guidance, you have a much higher likelihood of ensuring that everything has been removed. Pain relief is by either local anesthetic, intravenous anesthesia, or a spinal. But this is a more complicated procedure than a first trimester suction DNC. This picture shows the degree of dilation needed for a first trimester procedure versus a second trimester. And so each week of pregnancy, let's say 18 week, that is 18 millimeters, which is a significant amount of mechanical dilation, which can result in trauma. The intrauterine contents, the fetus, is removed using forceps like this. These are called Sofer forceps, and you can see how they will grasp the fetus and pull it out in pieces. You reach in and you pull out a leg, you pull out an arm, and you need to ensure that everything is removed. Dilation and evacuation.
Okay, so dilation and curettage versus dilation and evacuation.
The immediate complications would be uterine perforation. That's why it's important that this be done by someone who has experience and is technically trained. You can leave tissue in the uterus, placental tissue, and have retained fragments. Hemorrhage and infection are always risks, particularly with the advanced procedures. Delayed complications, if you have cervical trauma from too rapid dilation of the cervix, you could damage the...
I don't think he's Australian. No, he is, man. He's Australian. I know the guy. Med School Bro. Yeah, these videos, I was about actually to make some other videos to make fun of it. But I said, you know what? I'm not going to make fun of other creators. It's fine. Let him do his thing and I'll do my thing. Like these 60 seconds to diagnose the disease, it's so staged, bro. It's so funny. Oh, yeah. Yeah, these... Whatever. Like, maybe he's that good, but I don't think so. He's just yeah, 60 seconds to make the diagnosis, these videos. See this?
It's the diagnosis, full code
edition. We got full code. Okay, let's do it. So we have a pregnant patient, abdominal pain and headache coming into the ED. First things first, let's get a monitor and check these vitals out. 165 over 105. Okay, I want to start some hydralazine and make sure we can bring that blood pressure down before we check out the patient. All right, so looking at the patient, we have a 27-year-old, 38-week plus 5 days, increasing upper abdominal pain, bitemporal headache, reflux symptoms. I definitely want to do a neurological assessment of the eyes, seeing some spots in the vision. What about GIGU? Aching pain in the right upper quadrant. Okay, I'm thinking maybe liver pathology, maybe appendicitis, and neurological assessment. Head hurts everywhere. Okay, signs of maybe like some preeclampsia going on. Okay, so I want to do a coag panel. I want to do a CBC. I want to do a liver enzymes for sure. And I want to do a fetal Doppler to make sure the baby's okay. Perform. We have low platelets, elevated liver enzymes.
You got 10 seconds left.
This is, I'm thinking automatically here, HELLP syndrome. Let's get this patient handed off to OB and transfer to labor and delivery. HELLP syndrome. Yes, finish. Yes!
Jake.
Yeah.
I mean, that's fine, but... By the way, his rapid review books are awesome. Pretty sure those videos are rigged. I'm pretty sure too. Yeah. It can't be that good. So tired for some reason.
Fibers of the cervix, resulting in cervical insufficiency. And we'll talk about that later. Again, the earlier the procedure, the less the risks and the higher the rate of successful abortion. Notice the maternal mortality rate. It is half that of a term vaginal delivery. So if you look at overall the risks, even with an advanced pregnancy abortion such as a D&E, the maternal mortality and morbidity is less than a term pregnancy. So this is a surgical method. Another second trimester abortion option is labor induction. And here uterine contractions are stimulated by various agents. They result over time in dilation of the cervix. The agents used are varied. Historically, hypertonic saline was used. This is a 3. This is less than a term pregnancy. So this is a surgical tissue and have retained fragments. Hemorrhage and infection are dilation of the cervix. You could advanced procedures. Delayed complications, if you have cervical trauma from too rapid dilation of the cervix, you could damage the fibers of the cervix, resulting in cervical insufficiency. And we'll talk about that later. Again, the earlier the procedure, the less the risks and the higher the rate of successful abortion. Notice the maternal mortality rate. It is half that of a term vaginal delivery. So if you look at overall the risks, even with an advanced pregnancy abortion such as a D&E, the maternal mortality and morbidity is less than a term pregnancy. So this is a surgical method. Another second trimester abortion option is labor induction. And here uterine contractions are stimulated by various agents. They result over time in dilation of the cervix. The agents used are varied. Historically, hypertonic saline was used. This is a 3-molar solution which irritated the uterus and caused contractions, or you could use hypertonic urea. This is an intraamniotic injection. You can also use prostaglandins, and it is prostaglandin F2 alpha, which is used for these. These can either be intraamniotic infusion or intravaginal or intramuscular. And all of these bring about contractions of the uterus. Misoprostol is PGE1. Some of the effects of...
Okay, so labor induction. You induce labor by inducing uterine contractions, or you use hypertonic solutions, intraamniotic saline or intraamniotic urea, but they are irritating. Prostaglandins, intraamniotic prostaglandin F2 alpha, or vaginal prostaglandin E2, or intramuscular 15-methyl PGF2 alpha. Okay, I'm not going to memorize that. So prostaglandins, you can give them intraamniotic, vaginal, or IM. Intraamniotic, vaginal, or IM. Intraamniotic, vaginal, or IM. Intraamniotic, vaginal, or IM. Okay. Intraamniotic, vaginal, or IM.
Solution is it will result in death of the fetus. And when you have final expulsion of the fetus will be already dead. If you use prostaglandins, they will just result in contractions of the uterus, and you may very well have a live-born fetus, which of course is too early to survive. The induction to delivery interval, how long does it take to bring about cervical dilation and expulsion? It could be up to 24 hours. In many cases, if you're using prostaglandin, they will often inject into the amniotic cavity or into the cardiac muscle potassium chloride or digoxin. These will result in arrhythmias and cardiac arrest when the fetus does finally deliver, that it is not born alive. Immediate complications, retained placenta, and probably you're looking at 20% of cases will require a curettage to remove the placenta. Hemorrhage and infection are always risks, and the greater the gestational age, the more likely. Delayed complications are similar to those of a D&E, cervical trauma with resulting cervical insufficiency. Notice the maternal mortality is about the same as with a term delivery. So from a strictly medical standpoint, a D&E is safer for the mother than induction of labor. Now, if one is inducing labor because of a gross anatomic abnormality of the fetus and you want to do an autopsy, then you really need to have an intact body. And so the labor induction would be the way to go. If you do a D&E, you remove the fetus in fragments, and you can hardly do an autopsy because all you have is fragments of the fetal tissue. So that...
Why would you do an autopsy?
That is the same remove immediate will result cavity interval. How long does it take to bring about abortion such as a D&E? Another second trimester abortion option is labor induction. And here uterine contractions are stimulated by various agents. They result over time in dilation of the cervix. The agents used are varied. Historically, hypertonic saline was used. This is a 3-molar solution, which is prostaglandin. If you use prostaglandins, they will just result in contractions of the uterus, and you may very well have a live-born fetus, which of course is too early to survive. The induction to delivery interval, how long does it take to bring about cervical dilation and expulsion? It could be up to 24 hours. In many cases, if you're using prostaglandin, they will often inject into the amniotic cavity or into the cardiac muscle potassium chloride or digoxin. These will result in arrhythmias and cardiac arrest when the fetus does finally deliver, that it is not born alive. Immediate complications, retained placenta, and probably you're looking at 20% of cases will require a curettage to remove the placenta. Hemorrhage and infection are always risks, and the greater the gestational age, the more likely. Delayed complications are similar to those of a D&E, cervical trauma with resulting cervical insufficiency. Maternal mortality is about the same as with the term delivery. So from a strictly medical standpoint, a D&E is safer for the mother than induction of labor. Now, if one is inducing labor because of a gross anatomic abnormality of the fetus and you want to do an autopsy, then you really need to have an intact body. And so the labor induction would be the way to go. If you do a D&E, you remove the fetus in fragments, and you can hardly do an autopsy because all you have is fragments of the fetal tissue. So that is the second trimester procedure using labor induction. A rare procedure, which has major surgical risks, is doing a mini cesarean or a hysterotomy, or even removing the pregnant uterus intact. There are high risks, both in maternal morbidity and mortality. It is rarely used as an abortion procedure because of these major risks. The main indications would be invasive cervical carcinoma. Let's say you have cervical carcinoma stage 2B, where the treatment would be a radical hysterectomy. If this is identified, let's say at 16, 17, 18 weeks, then one of the procedures may be a hysterectomy. Or if you have uncontrollable hemorrhage, which you cannot control, failed labor induction, that would be also an indication. But this is very rarely done. Notice the maternal mortality is significantly higher than any other procedure, 50 per 100,000.
You gotta shift into questions after this lecture. I feel like I'm very bored right now. I can't even focus. So I think so. I'm gonna shift to questions. You're right.
2,000, but that is far higher than any other procedure. And so this should be used with very, very limited indications.
Okay. Induced abortion, 50% of pregnancy. Okay. What is M&M?
Are aborted. The risk of abortion, morbidity and mortality.
Okay. All right, so I just want to review the types. First trimester, you have surgical DNC, and you have medical, which is oral mifepristol and oral misoprostol. And second trimester, you have D&E, surgical, and you have labor induction using saline and Yeah, DNA. Labor induction, saline. Saline, prostaglandins, misoprostol. And you have second trimester surgical. Second trimester hysterotomy, hysterectomy. Yeah. Okay. All right, let's do some questions. Oh my god, bro. Like, take a look at this. Okay, let me close that. How much to extend actually the QBank? Oh, that's nice. $50. That's nice. Okay. Okay, it worked. Alright, I'm gonna go to the bathroom and come back. Zach? No, yesterday. I hope you do better in questions now. Yeah. I mean, I haven't just... I didn't do a lot of... videos, so... Actually, I'm gonna eat right now, so... I'm gonna watch a lecture. Instead of... after I finish eating, I'll...
All right, we move now to spontaneous abortion. Probably about 15 to 20% of recognized pregnancies will spontaneously abort. Here's our case. A 40-year-old woman, gravid 3 para 1 AB1, so this is her third pregnancy. She's had one pregnancy that went beyond 20 weeks and one that was a spontaneous or induced abortion. She comes in at 9 weeks gestation complaining of vaginal bleeding. And this is very common, very common. A urine pregnancy test was positive 3 weeks ago. She initially experienced breast tenderness, and breast tenderness is one of the presumptive evidences of pregnancy, but it's gone. I don't like this. Recognized pregnancies will spontaneously abort. Here's our case. A 40-year-old woman, gravid 3 para 1 AB1, so this is her third pregnancy. She's had one pregnancy that went beyond 20 weeks and one that was a spontaneous or induced abortion. She comes in at 9 weeks gestation complaining of vaginal bleeding. And this is very common, very common. A urine pregnancy test was positive 3 weeks ago. She initially experienced breast tenderness, and breast tenderness is one of the presumptive evidences of pregnancy, but it's gone. I don't like this. Pregnancy test was positive, initially breast tenderness, that's gone, and now she's bleeding. Now she has not passed any tissue at this point. Let's see how we're going to assess this. Here is a chart that we're going to look at to explore the possible managements of first trimester bleeding. The first thing we're going to do is to do a speculum exam and to see if there is any cervical or vaginal lacerations or lesions, and to identify if the cervical os is open or closed. An ultrasound will tell us, do we have a viable or non-viable pregnancy? Is the gestational sac intact? Have some of the products of conception been passed with some left, or are they all gone? We always need to consider with first trimester bleeding, could it be an ectopic pregnancy? Or could it be a molar pregnancy? So cervical vaginal lesions, ectopic pregnancy, molar pregnancy. If the cervical os is closed, ultrasound shows a viable pregnancy, we call this threatened abortion. Management, observation. If the pregnancy is going to be lost, there's probably nothing you can do to prevent it anyway, because the most common cause of first trimester loss is aneuploidy. If the cervix is closed and the ultrasound shows a non-viable pregnancy, no cardiac motion, an empty gestational sac, that is what we call a missed abortion. Actually, I prefer the term embryonic demise because it's probably already dead. This can be managed a variety of ways. A scheduled D&C, where you aspirate the urine contents, is a reasonable approach. Another would be just to await and let her see if she passes everything on her own. I've had patients who have elected to do that who said they were in labor for 2 days. And that they did not particularly appreciate. The other possibility is they may pass some of the tissue, but others remain. Then she has to have a D&C anyway. So I think a reasonable approach is a scheduled D&C. The other thing you could give is to give misoprostol, prostaglandin E1, to help contract the uterus. If we look at the cervical os and find it is open, and if ultrasound shows the gestational sac is intact, she hasn't passed anything yet, but once the cervix is open, it's just a matter of time. This is called an inevitable abortion. Management is going to be emergency D&C, because if she's bleeding, she can lose a lot of blood if you just wait even a few hours. If the cervix is open, some of the tissue has been passed, but the ultrasound shows some is still left inside. We call that an incomplete abortion. This also needs to be managed with an emergency D&C.
Did you go to any states beside Buffalo? No. You mean like in New York State? I went to Albany, I went to New York City, but all of them is in one state, which is New York.
This is open. Ultrasound shows a clean uterine cavity, no placental tissue, no fetal tissue. All the products of conception are gone. That is completed abortion, and the management here is just observation. All right, let's look at some pictures. The most common are gone.
So, if somebody has closed cervix and viable pregnancy and she's bleeding, is that a threatened abortion just because she's bleeding?
Look at to explore the possible managements of first trimester bleeding. The first thing we're going to do is to do a speculum exam and to see if there is any cervical or vaginal lacerations or lesions, and to identify if the cervical os is open or closed. An ultrasound will tell us, do we have a viable or non-viable pregnancy? Is the gestational sac intact? Have some of the products of conception been passed with some left, or are they all gone? We always need to consider with first trimester bleeding, could it be an ectopic pregnancy? Could it be a molar pregnancy? So cervical vaginal lesions, ectopic pregnancy, molar pregnancy. If the cervical os is closed, ultrasound shows a viable pregnancy, we call this threatened abortion. Management, observation. If the pregnancy is going to be lost, there's probably nothing you can do to prevent it anyway, because the most common cause of first trimester loss is aneuploidy. If the cervix is closed and the ultrasound shows a non-viable pregnancy, no cardiac motion, an empty gestational sac, that is what we call a missed abortion. Actually, I prefer the term embryonic demise because it's probably already dead. This can be managed a variety of ways. A scheduled D&C, where you aspirate the urine contents, is a reasonable approach. Another would be just to await and let her see if she passes everything on her own. I've had patients who have elected to do that who said they were in labor for 2 days. And that they did not particularly appreciate. The other possibility is they may pass some of the tissue, but others remain. Then she has to have a D&C anyway. So I think a reasonable approach is a scheduled D&C. The other thing you could give is to give misoprostol, prostaglandin E1, to help contract the uterus. If we look at the cervical os and find it is open, and if ultrasound shows the gestational sac is intact, she hasn't passed anything yet, but once the cervix is open, it's just a matter of time. This is called an inevitable abortion. Management is going to be emergency D&C, because if she's bleeding, she can lose a lot of blood if you just wait even a few hours. If the cervix is open, some of the tissue has been passed, but the ultrasound shows some is still left inside. We call that an incomplete abortion. This also needs to be managed with an emergency D&C. If the cervix is open, ultrasound shows a clean uterine cavity. No placental tissue, no fetal tissue, all the products of conception are gone. That is completed abortion, and the management here is just observation. All right, let's look at some pictures. The most common cause of first trimester loss is aneuploidy. We already talked about that. The most common cause is Turner syndrome, trisomy 16. We mentioned that previously as well. 98% of Turner syndrome conceptions are spontaneously aborted. An uncommon cause of recurrent pregnancy loss is anticardial lipid antibody. This is where a woman develops antibodies against the fetal tissues or the placental tissues and results in recurrent pregnancy losses. We'll talk about that more under thrombophilias. The management for this is heparin, subcutaneous heparin. Let's look at ultrasound in evaluating first trimester bleeding. A common way of looking at the uterus historically was a transabdominal ultrasound. And this looks at the uterus and what's inside. Now you can appreciate that you're going to have to pass the ultrasound beam through the maternal abdominal wall. What if you have a big mama, weighs 300 pounds? That's going to be pretty hard to see. So an alternative is to use a vaginal probe. With a vaginal probe, you approach the uterine cavity through the vagina, and it doesn't matter whether she's 100 pounds or 300 pounds, you can see just as clearly. So if you're going to order an ultrasound because of first trimester bleeding, I would suggest do a transvaginal ultrasound rather than a abdominal ultrasound. This is a transvaginal ultrasound, and what we can see here is a small gestational sac. Now this is an early sac. You don't even know if there's an embryo in there. It's too small. You can see a nice decidual reaction, which is around the gestational sac. This is 4 weeks and 1 day. Here we see a nice, round, smooth, fluid-filled gestational sac. Too early yet to see any embryo. Here we see a nice, round, smooth gestational sac, and here we have the fetal pole right here. Now, I don't know where the head is. I don't know where the butt is. This is a crown rump length.
Okay, so open all gone, open some left, incomplete, complete. Gestation sac impact inevitable. Okay, so that's the cause of first trimester bleeding. Okay, so we gotta do a speculum exam, he said.
Let's see how we're going to assess this. Here is a chart that we're going to look at to management of first trimester bleeding. The first thing we're going to do is to do a speculum exam and to see if there is any cervical or vaginal lacerations or lesions, and to identify if the cervical os is open or closed. An ultrasound will tell us, do we have a viable or non-viable pregnancy? Is the gestational sac intact? Have some of the products of conception been passed with some left, or are they all gone? We always need to consider with first trimester bleeding, could it be an ectopic pregnancy, or could it be a molar pregnancy? So cervical vaginal lesions, ectopic pregnancy, molar pregnancy. If the cervical...
Okay. Makes sense. All right, let's do questions. Which of the following is the best next step in management of this patient? Administration of which of the following is the best... all right, ultrasound shows a fetus in cephalic presentation, and amniotic fluid maximum vertical pocket is 0.1. I think we solved that yesterday, didn't we? And I got it wrong. This is the answer. Yeah. So that indicates pre-ROM or premature rupture of membranes. I got it wrong. I think I picked oxytocin. Right, so premature rupture of membrane refers to spontaneous rupture of membranes at less than 37 weeks gestation and prior to the onset of labor. Management of pre-ROM depends upon gestational age, fetal status, and the absence of chorioamnionitis. Management of pre-ROM, P-PROM, not pre-ROM, P-PROM, at 32 weeks gestation who have normal fetal testing and no signs of chorioamnionitis, includes administration of antenatal corticosteroids to accelerate fetal lung injury maturity, and of antibiotics to prolong latency. Okay. Which of the following is the best next step in management? Alright, maternal and fetal vital signs are unchanged from initial presentation with the exception of increased contraction frequency. Alright, what is the physical exam? Both the fetal head and hand are applied to the cervix. Yeah, I think I just said I'm going to mark this question. Alright, which of the following is the most likely diagnosis? A transvaginal ultrasound shows globular uterine enlargement, cystic. Okay, that's the easy one. That's adenomyosis. Yeah. In addition to a pelvic ultrasound, which of the following is the best next step in management? In addition to a pelvic ultrasound, alright, an endometrial biopsy shows a proliferative endometrium. Alright. Regular menstrual bleeding. She's 47. Menses typically get 30 days. Fine. Okay, probably gonna give her. Okay, that's not. That's not. What are we gonna give? Intramuscular leprolide. I feel like it's gonna be C. This patient presents with intermenstrual uterine bleeding and irregularly shaped uterus. Where is that? Bimanual pelvic shows irregularly shaped uterus. Mild anemia, endometrial biopsy showing proliferative endometrium. This presentation is characteristic of AUB, menstrual bleeding, which is of normal volume, duration, or intensity. Her irregularly shaped uterus is suggestive of leiomyoma. What? I thought the problem is endometrial proliferation, like endometrial hyperplasia. I thought we're treating this. What is that, man? Stupid. AUB refers to menstrual bleeding that is of abnormal volume, duration, intensity, or frequency. AUB in patients who have an irregularly shaped uterus may be due to uterine leiomyoma, a common cause of intermenstrual bleeding. First line treatment of AUB is with combination OCPs. Oh. Huh. Uterus is suggestive of leiomyoma. Isn't that a stupid question? I picked C because I was looking for progesterone only, but turns out you gotta give her the pill, not an implant. I wanna see why C is wrong. Although oral progesterone formulation can be used, the subcutaneous implant is associated with irregular uterine bleeding and can exacerbate AUB. Huh. When I think about leiomyoma, I think younger women, but wow, they actually become symptomatic in older women in perimenopause. Like this woman, 47. Okay, the adenomyosis, what did she present with? Heavy and painful menses. Okay. Which of the following complications is this patient most likely to experience? Which of the complications is this patient? Okay. It's weird that it's bilateral. Firm and swollen bilaterally. I knew dicloxacillin treats mastitis, but I thought this is an abscess here. Okay, I thought of this too. It's not fluctuant. All right. Oh, cold compresses. Damn. This is wrong. Makes sense. The phone is the most likely diagnosis. Okay, we said if it's if it's 3 centimeter in diameter or more, we gotta. Oh, it's not asking about the. Bro, keep going. Thanks, Amr. Appreciate you, bro. Palpation, the mesocystic, non-tender, mobile, approximately 3 centimeter in diameter. Wow, there's a lot of cysts here. Left vulva appear visibly swollen. I think it's just Bartholin. Okay, why is not B and E? Gardner duct cyst typically occurs in the anterolateral wall of the proximal third of the vagina. Okay, so here's posteriorly. I have a third one actually. I have a third energy. Gonna leave it when I need it. Okay, Gardner's duct cysts typically occur in the anterolateral wall of the proximal third of the vagina. Anterolateral wall. Okay, let's see. Gardner duct cyst. Okay, so Bartholin is like this is Bartholin because it's posterolateral, or like posterior introitus, and the vulva is swollen. Okay. see the Gardner cyst. Okay, that's nice. Bartholine glands right here. Skin glands on top. Skin glands on top. Bartholine. Shall I get the screw one, bro? Thank you so much, Habibi. I really appreciate that. Thank you, Amr. In biological terms, a cyst means thin-walled organ. Okay, this is Bartholine. This is Skene. And this is Gardner. This is Gardner in the middle. Oh, damn. That is big. Okay, let's see why it's not B. Typically occur in the anterolateral wall of the proximal third of the vagina. This patient's mass is in the posterior vagina. Okay. Lateral to the urethra, so on top. Here. Here. Bartholine cyst. Gardner cyst in the middle. Skene duct cyst on top. Bartholine cyst. Skene. Bartholine. Gardner. Okay. Left vulva is swollen, so Bartholine cyst. Left vulva is swollen. Specular examination shows a mass in the left vagina near the posterior introitus. Which of the following is the most likely cause of these findings? Pelvic exam, multiple flesh-colored pedunculated papules on the vulva. Isn't that HPV? Excisional biopsy is carried out. Yeah. Which of the following test is most likely to provide definitive information for this patient? Okay, the patient was subsequently tested and her FMR1 gene shown to have 180 cGG. Pregnancy is affected by Fragile X. She is 14 weeks gestation, so that's yeah, so definitive information. That is after 15 weeks. That is screening. This is not definitive. Bro, no way. It's 15 weeks, not 14. Yeah, see? Amniocentesis performed at 15 or more weeks. That is so stupid, actually. No way, bro.
شربت مانجو يا سينا صح؟
Do you recommend solving your ultra step 1 for the first time in tutor mode or test mode? Need to hear your opinion, please. I'll tell you. So, if you're getting like on random blocks, if you're getting 70s, 80s, that means your foundation is good. You can keep doing that and only pick the systems that you're weak in, that you feel you're weakest at. If you're like getting 40s and 30s or 50s, that means you have a deficit, like you have weakness in systems, and probably most systems. So I would suggest doing it system-wise and tutor mode, if that's the first time for you doing view roll. I hope that helps. You're very welcome, bro. Thanks for joining. All system blocks in tutor mode, or just first two blocks, then the rest in the test mode? I don't really understand the question. Okay, so let's say you have a weakness in cardiovascular, right? So do the blocks tutor mode. Tutor mode, if you have like a severe weakness in cardiovascular, do the systems, the cardiovascular, all the blocks tutor mode. Okay. Because I'll tell you why, so that you understand why you're doing this. Tutor mode is basically your brain is wondering why a certain answer is, why is this wrong, why is this right. You're basically having a lot of questions about this question. So in tutor mode, you get to see the answer right away, quickly. So you answer your brain's questions. So the answer or the information stick better. Instead of just solving the entire block and then reviewing it after that, you'd probably forget some of the information that you've gained in the beginning. You know what I mean? Yeah. Yeah. If you have severe weakness in cardio, solve it all in tutor mode. But try to finish try to finish questions quickly, like I'm doing right now. You know, I'm reading the last part. Even though I'm not solving it timed, I still care about how much time I spend in the block, you know? You don't want to, sleep while you're doing the questions. You want to keep your head engaged. So... What the fuck? Beta HCG is 56,000. That's probably hydatidiform more. What do we do? Thank you very much, Dr. Yassine. I appreciate it. You're welcome, bro. I appreciate you joining me. Thank you. Alhamdulillah. يعطيكم الصحة. You mean this question? No, this question is not A. This question is C. Yeah, what was your worst section in step 1? I think CNS was my worst. Actually, CNS and cardio were my worst subjects. CNS, oh god, me too. Yeah. Remember when I told you when we were taking the CNS in med school, I was in Albany, College of Pharmacy. I was doing a semester here. So I had to study CNS along with cardiovascular in med school. So I was very bad at them in step 1. Subchorionic bleed. Okay, I don't know how much the beta HCG should be in like 2 beta HCG levels in pregnancy. Yeah, I'm too much physiology. Yeah. Oh wow. Okay, so that's normal then. For me, ethics and biostats were the worst. Yeah, so they weren't really my worst. Ethics were good because I did AMBOSS questions, all AMBOSS questions, and I studied them as I'm studying OB-GYN right now. So they were really good for me. Right answer is C. This patient presents at 8 weeks gestation of vaginal bleeding with cervix. So. Okay, so she's bleeding because she has a hematoma between the chorion and endometrium. I wonder how long am I gonna get these questions wrong, to be honest. I don't know. Like, I'm getting them, even these questions that are very easy, I'm getting them wrong. It's so annoying. The only reason I got this wrong is because I thought the 56,000 means hydatidiform mole. But actually, in normal pregnancy, these are the levels. Correct answer is C. I mean, it's not that hard to market. This question is easy. That's why I'm pissed off. But I didn't know this like crescent-shaped area between the chorion and endometrium. I didn't know what's that. It's just bleeding. 1 by 2 by 1 centimeters hypoechoic crescent-shaped area. Okay, and she's bleeding. And the cervix is closed. Did you study radiological findings in step 1 along with microscopic pics or else? What do you mean? Of course I did. I actually need to change my nicotine patch. See, I'm having a patch here. 1 second.
وبعدين في قطة ليك
عم حوالي ساعة بالليل مفيش ولا مكان يعني الساعة 5
الايجنتس واخدين بالك
ايش لا
جيمرز فظاع
You know, during like the final year of med school, like 6th year, I had like very stressful finals, and I didn't study for like the entire year, so I had to cram a lot. So at that time, I found smoking very helpful. So I started smoking about 7-8 months ago, like smoking cigarettes in Egypt. And I liked it. I liked it so much that I, in just 2 months, I was smoking 2 packs a day. Can you imagine? 2 packs, 40 cigarettes. So, I realized, okay, I'm gonna die this way, right? I'm gonna get heart failure, whatever. So, that's the new one. So I realized I gotta stop or I'm gonna die. And then I decided to just completely switch from cigarettes to vaping. And then I said to myself, okay, so even vaping doesn't work. Even vaping is bad. So I tried to quit on my own, but I couldn't. The cravings were so bad. Like I would crave smoking so bad. So I went to the physician here when I came to America, and I told him I need to quit, but I can't. You know, I have these cravings. He told me, "Are you ready to quit?" I said, "Yeah, for sure. I don't want to die." And then he wrote, like, the protocol for here in America is that you get nicotine patches 21 milligrams a day, then for 6 weeks, and then 14 milligrams a day for 2 weeks, and then 7 milligrams a day for 2 weeks. Yeah, I was that was like 4 or 5 months ago. So when I tried these nicotine patches, they were so good. Like, they were very, very, very nice, and I didn't have any desire to smoke or vape or whatever. So I completely quit. It's been about 2 weeks. I haven't smoked anything at all. Okay, this is threatened abortion because... How is this... Okay, wait. Yeah, because it's closed cervix. And there's bleeding. He said if it's closed cervix and there's viable pregnancy, it's threatened abortion. And the next step is observe. Okay, wait. What did he mean by observe here?
Measurements of first trimester bleeding. The first thing we're going to do is to do a speculum exam and to see if there is any cervical or vaginal lacerations or lesions, and to identify if the cervical os is open or closed. An ultrasound will tell us, do we have a viable or non-viable pregnancy? Is the gestational sac intact? Have some of the products of conception been passed with some left, or are they all gone? We always need to consider with first trimester bleeding, could it be an ectopic pregnancy? Could it be a molar pregnancy? So cervical vaginal lesions, ectopic pregnancy, molar pregnancy. If the cervical os is closed, ultrasound shows a viable pregnancy, we call this threatened abortion. Management, observation. If the pregnancy is going to be lost, there's probably nothing you can do to prevent it anyway, because the most common cause of first trimester loss.
Okay, they're saying here that you gotta do a serial ultrasonography. A subchorionic hematoma refers to bleeding between the chorion and endometrium that occurs when the chorion partially detaches from the endometrium. Although patients with threatened abortion and subchorionic hematoma are at increased risk of early pregnancy loss, there is no known treatment, and patients are followed with serial ultrasonography to assess for hematoma expansion and fetal viability. Wow, you don't even like get rid of the hematoma? You just leave it there? Hypoechoic area is likely a subchorionic hemorrhage. Okay, so we have the digital cervix examination shows the closed cervix. And she has bleeding. First trimester bleeding. Okay, wait. Alright, so I gotta study this very well, actually.
A 40-year-old woman grabbed a 3-para-1-AB1, so this is her third pregnancy. She's had one pregnancy that went beyond 20 weeks and one that was a spontaneous or induced abortion. She comes in at 9 weeks gestation complaining of vaginal bleeding. And this is very common, very common. A urine pregnancy test was positive 3 weeks ago. She initially experienced breast tenderness, and breast tenderness is one of the presumptive evidences of pregnancy, but it's gone. I don't like this. Pregnancy test was positive, initially breast tenderness, that's gone, and now she's bleeding.
It made me feel sad, bro. You started smoking medical school in the final year. Hope you are now getting better and better. Yeah, I was actually very sad myself too, but alhamdulillah, I stopped. So I'm never gonna go back. It's very bad. Like all the time I was smoking. You know, I had like dopamine hits and stuff, but in my head, I know that I'm actually destroying my life. So when I stopped that, I feel like I was reborn again. You know.
She has not passed any tissue at this point. Let's see how we're going to assess this. Here is a chart that we're going to look at to explore the possible managements of first trimester bleeding. The first thing we're going to do is to do a speculum exam and to see if there is any cervical or vaginal lacerations or lesions, and to identify if the cervical os is open or closed. An ultrasound will tell us, do we have a viable or non-viable pregnancy, is the gestational sac intact? Have some of the products of conception been passed with some left, or are they all gone? We always need to consider with first trimester bleeding, could it be an ectopic pregnancy, or could it be a molar pregnancy? So cervical vaginal lesions, ectopic pregnancy, molar pregnancy. If the cervical os is closed, ultrasound shows a viable pregnancy, we call this threatened abortion. Management, observation. If the pregnancy is going to be lost, there's probably nothing you can do to prevent it anyway, because the most common cause of first trimester loss is aneuploidy. If the cervix is closed,
Okay, so this woman probably has aneuploidy.
and the ultrasound shows a non-viable pregnancy, no cardiac motion, and
It's weird, actually. This patient presents at 8-week gestation with vaginal bleeding, closed cervix, an intrauterine pregnancy with a normal heartbeat and a hypoechoic. This presentation is consistent with a threatened abortion, which is bleeding at less than 20 weeks gestation. What's the definition of abortion? Doctor, do you recommend boot camp? What is boot camp? Oh. Med school. Something like BMB, I think. My brother used boot camp for DAT. Wow, they have a lot of good reviews. Imagine using med school boot camp is light years better than Boards and Beyond. Like, they're basically shitting on Boards and Beyond. That is so like that is so disrespectful. Actually, like I'm doing something like this, by the way. Like I was trying to do, look. So this is like my new website. Wait, I'll show you guys 1 sec. Anyway, so I was trying to make like a website like that, which is which is like small sized quizzes along with text and imaging and stuff, you know, so that when you go through the the explanation stuff, you just understand more. Like for example, this QBank is nice, but this is a very huge question. Like it's testing 10 different topics or 10 different pieces of information, right? Imagine in addition to this question, you have like 10 smaller questions that you know, that help you understand this. For example, like for here, in order to understand this, you have to understand what is the definition of abortion, right? And then after that, you have to understand what is threatened abortion, you know? Imagine that you have, so you keep solving questions instead of just reading explanation. That was my goal from the website. Do you have a website? Yeah, I do. 1 second, I'll get it for you guys. Basically, I was trying to do just like boot camp. I didn't realize that this is exactly what I'm doing. Wow. Okay, how am I gonna compete with these people? Do you think I can compete with these people? Study medicine in one place, not all over the place. Oh my god, this is this is exactly what I'm trying to do, bro. Wow. I was bouncing around 5+ different resources trying to learn medicine, how to prepare. I wish I had one resource that's distilled what I need to know with high yield videos, tons of practice questions, cheat sheets, medboot that I wish I had when I was school. Alright, so you know what? I'm sorry, bootcamp, but I'm gonna take your customers. Oh no. So my company it's called Med Challenge Arena. I'll show you the Med Challenge Arena. Okay, 1 second. I'll get you the website right now. Explain more what you're doing in your website. What's your idea? So this is the website, okay? Like this is my logo. It's called Med Challenge Arena. So my idea was, it's 2 parts, okay? It's a question bank that you get to solve questions against your friend. So, you know, instead of me just solving this like on my own, I have another person in front of me that is, you know, that has a score and stuff. So I'm doing these questions on my own, and he's doing it like one-on-one, right? So we're competing against each other, and then we get a score and animations and stuff like that. That was my original idea. So I made this. This is my logo. I'll show you guys. So this is my logo. What do you think of my logo? Is it nice? Will be your first customers. I really appreciate it, man. Thank you. What do you think of the logo? And I have like an animation too. Look. Wait. Oh, that's fast. Wait. It has a sound. Wait. Yeah, so an unorthodox way of learning means like an atypical way of learning. So that, you know, instead of just solving questions on your own and going through the entire QBank on your own, you can just go against a friend and you know, and fight against your friends. Love these fighting stethoscopes. Thanks, man. Yeah, I paid $70 for somebody to make these. I had an idea and I paid him so that he makes it. So that he made it. So yeah, so that my idea. That was my idea. The website is still like early. Okay, wait. It's now very preliminary though. So this is like my admin panel. This is the only thing that's done. Like I go in, and this is the first part of the website, which is I add questions. Where is it? So I add questions like in a row, but it's still very early. Like scope. So I didn't really want to like make videos about it or whatever because it's not ready. So it's still under construction. Yeah, it is. It is under construction, unfortunately. I would love to say, go ahead and play it, but it's not ready. But inshallah soon enough it will be ready. The hard part though is that I have to create a very high quality questions and with explanations, just like your world. But I don't like that because I don't want to make a lot of explanations like this. I don't want to make all these like. Do you see how much time do I spend on reading here? I don't want this to happen in my game. Like, this is a game, right? So you're not supposed to read a lot. So it's gonna be questions focused. So instead of giving you the information in a written way, I'm gonna give it to you by you solving questions and going like through them. So it's you keep active learning instead of passive learning and reading. But I have no other choice other than reading that because there's nothing for step 2. Yeah. Which of the following is most like diagnosis? Looks at a great idea, but I recommend starting it after you're done with step 2. I've been doing this idea for over a year now. So it's just coding takes a lot of time. Thank you so much. Appreciate it. So coding takes a lot of time and a lot of mistakes happen too. Like I hired some Indian guys. They did a very bad game. I actually want to show you the game before that. 1 second. Can show you the game. How it was. I'll show it to you in another stream. So yeah, I'll show it to you in another stream. I'll just show you some screenshots. Yeah, so this is like my earliest design. So this is like the profile. You have the name here. You have it's called unranked points. So it's gonna be a rank too. There's gonna be like met points. There is player rank, because I used to play video games. I used to play League of Legends, so I was addicted to the idea that there is ranking. There's a win rate. There's a number of questions solved. There's like your university, And this was like the earliest design, but I kind of hated the design a little bit. I want it to be better. But this is like the earliest design I had. There's a time, there's score, there's some animations too. But, this is like the, you click on challenge and you look for a person to play with. Who does these thumbnails for you? Sometimes I do it myself. And this guy, Muhammad, he offered to do them for me for free. So he did the last couple of thumbnails for me. He's a very good guy. Large amount of intraperitoneal fluid. Is that Meigs syndrome? I think that's Meigs syndrome. right ovarian mass with thick septations and and excrescences. It feels like a teratoma, but I'm gonna pick adenocarcinoma. This is Meek syndrome, isn't it? Okay, I screwed up. Meek syndrome. Ascites and pleural effusion. Large amount of intraperitoneal fluid. Okay, she didn't have pleural effusion. 64-year-old adnexal mass on pelvic examination. The differential diagnosis of adnexal mass include benign, malignant ovarian cyst, metastatic disease, benign. Evaluation of post on ultrasound. Benign adnexal masses are generally simple, fluid-filled, and thin-walled. In contrast, malignant adnexal masses are generally complex, contain solid components, and have thick septations and walls. This patient's ultrasound, therefore, is suggestive of malignancy, and the large amount of intraperitoneal fluid is concerning for ascites, is indicative of disseminated disease. The most common type of ovarian malignancy is epithelial carcinoma. Oh, stomach. I read that ovary. Tubular adenocarcinoma or carcinoma of the ovary. Oh, that's a stupid answer. What the hell? Definitely not that. There's a right ovarian mass, for God's sake. Okay, I read that wrong. My bad. Should have eliminated this. Mature cystic teratoma. I should have picked D, though. I don't know why D is wrong. Can present as complex adnexal mass. Ultrasound shows a cyst that contains a hyperechoic nodule, punctate or linear echoes, and areas of calcifications. Right ovarian mass with thick septations and excretions. Excrescences. Okay,
excrescence. Excrescence.
Excrescence. Alright. Why did you think of teratoma, though? She's yeah, I shouldn't have thought of that. She's old. Teratoma affects younger women. I thought because thick septations. Because it's divided. The teratoma is also divided. That's where the cystic comes from. It has cysts in it. Cyst contains hyperechoic nodules, punctate or linear echoes. That's what I was looking for. Punctate or linear echoes. Punctate or linear echoes. Okay, thick septations, excrescences, normal uterus, left ovary, large amount. Thin-walled. Thin-walled, fluid-filled. This is thick septations. This is complex cyst. So simple unilateral, this is complex. This is more malignant. Malignant adnexal masses are generally complex, multilocular, contains solid components, excrescences or nodules. Okay. What is the meaning of excrescences there? Oh, okay. Excrescence is like this. I remembered from Pathoma. It's like this. Yeah. Alright. Excrescence and nodules. And have thick septations and walls. This patient's ultrasound therefore suggests malignancy and the large... Yeah, actually teratoma is so stupid to think about. She's old, which is the most likely diagnosis, which is the most likely ovarian cancer? It's definitely epithelial carcinoma. Although patients with epithelial carcinoma can present with abdominal pain, bloating at early study, many patients are asymptomatic. Okay. Okay, which of the following is the most likely diagnosis? Pelvic examination shows a tender, immobile, 6-week sized uterus. I guess she has a risk factor of leiomyoma because of the enlarged and irregularly shaped. Wow. You don't CT pregnant ladies generally? Yeah, I didn't know what to pick. I picked anything. I said maybe there's a stone or something. Yeah, good job, Omri. It's actually what you said exactly. CT scans are generally avoided during pregnancy. Okay, I didn't know that you have to give them daily antibiotic, low dose antibiotics till the end of the pregnancy. That's new to me. Okay. Yeah, sure. Yeah, asymptomatic bacteria is treated in pregnancy. If not, pregnant bacteria is not treated with antibiotics. No, asymptomatic bacteria is treated because it increases the risk for preterm labor. Bro, look at this question. It's crazy. Oh. I thought only estrogen and OCPs, you don't give them deep vein thrombosis, but even estrogen alone, you don't give it. Gabapentin. It couldn't cause acute pyelonephritis for the lady and stillbirth. It could cause acute pyelonephritis. Yeah, it can cause preterm labor. I'm actually so annoyed right now. I feel like I'm getting so many questions wrong, and I'm not learning anything. I know this is the correct process to do it. Like, I tell my students to do that, but like, I understand what they're going through right now. Gabapentin for hot flashes, yeah. If you have contraindications for estrogen and transdermal estrogen and vaginal estrogen, you give gabapentin. I didn't know that either. Look how many questions are wrong. Like, the entire block is wrong. Shit. Which of the following is the most appropriate next step in management? Microscopy. On physical examination, mucopurine discharge is seen on the ectocervix. Alright, that's these are diplococci, so this is gonorrhea. This is cervicitis. Gonorrheal cervicitis. I think we gotta give her okay. Thank God I got a question right. Which of the following is the best next step in management? Digital cervix examination shows the cervix to be unchanged. Okay. That's protracted labor, I guess. 37. Gravida 2, para 1. 41 weeks of gestation. Holy. Comes to the emergency department because of contractions that started several hours ago. Pregnancy. She has gestational diabetes. Two hours later, nothing happened to the cervix. So we give oxytocin to stimulate contractions. Oh, I can't believe I got an obstetrics question right. Active phase arrest occurs when a patient is dilated to 6 centimeters and has less than 1 to 2 centimeter per hour of cervical dilation. The most common cause of active phase arrest is hypocontractile uterine activity, contractions that are too weak or infrequent. I wonder what is the normal number of contractions. Have you tried other resources? No, I haven't. Do you have any options? I hated ops in med school. Yeah, yeah. It's annoying actually. Probably because the resources in medical school sucks. It's not created for you to learn anything. It's just you know. The initial treatment of active phase arrest is oxytocin, which increases uterine contraction frequency and intensity. Shit, man. Okay, I got this wrong because you do the rectovaginal culture in 36 weeks, right? 36 weeks. Yeah, 36 or 37 weeks gestation. So you can do C. Urine dipstick, no glucose, trace protein. Triural. قصر العيني book. I read that crap for 2 weeks straight. Yeah. No, thank God. I didn't open Alexander University books. I didn't even bother. I knew it would suck from even like the beginning. So I didn't waste any time with it. Okay. Why did we do 1 hour glucose challenge test here? Oh, because she's 26 weeks. Yeah. You do glucose screening. I mean, your world is the same. Like it's another question. Like, what's the difference? I mean, I'm gonna get the questions wrong as well on your world. So. Rectovaginal culture is typically okay. 32, uncomplicated, no chronic medical problems, vital signs, no glucose trace protein. Next step is to consider routine second and third trimester prenatal care. Okay. The goal of prenatal care is to maximize the likelihood of uncomplicated delivery and minimize maternal risks. This is accomplished by a series of interventions, assessments, and evaluations, which are timed. You know what? I need a paper or like a place where they have all the pregnancy screening guidelines. I need to memorize that shit. Okay, so yeah. So Bartholin cyst. On examination, the right vulva is swollen. Mass in the right vagina near the posterior introitus. That's Bartholin cyst. If it is less than or equal to 3 centimeters, you use warm compresses and sitz bath. If it's more than 3 centimeters, you do incision and drainage, and water, word catheter or marsupialization. This one, yeah, she is at labor, so I swear I would even get this question wrong again. So what are your plans for tomorrow? Same, like until I finish obstetrics and gynecology, I'll finish all the questions, all OB and gynecology questions and all the videos of Kaplan. I'll see if that works. Why is there no sound? I mean, besides studying, I think I'm gonna hang out at night with one of my friends. But I'm not sure if he's down though. Like every Saturday we go out, but maybe he'll say I have studying to do. So, what about you? What do you have? Do you have any plans? Wink, wink. Damn. I'm heading to Indiana tomorrow. Indiana? What are you gonna do in Indiana? It's a very cool animation. You gotta like that video. McRoberts position. Okay. Oh my god. This is so dangerous, bro. Imagine like the contractions keep pushing him like that. Shit. Oh no. Okay, so that's what's being mentioned here. Visiting my family, I live in Nashville by myself. Oh damn. Do you pay rent on your own? How do you pay rent? Do you work? What is the nuchal cord? Is the nuchal cord just the umbilical cord? Is that what it is? Okay, nuchal cord is like the umbilical cord wrapped around the... Alright. Oh damn, tight nuchal cord. Why is that a sign of shoulder dystocia? So you flex the patient. Okay, which of the following is the best next step in management? In addition to advising the patient to stop pushing, yeah, flex the patient's hip against her abdomen. That's McRoberts position. And then call for help. Apply suprapubic pressure. Enlarge. So you're originally from Indiana? Where's that? Where's Indiana? Oh. I feel so tired right now. It's a long story, maybe when I talk to you on Discord. Okay, sure. I feel so tired right now. Oh. Flex the patient hip. Press on the suprapubic. And episiotomy. Okay, that is an easy one. Okay, let's see what's that. Okay, 33-year-old woman, Gravida 2, Para 1. Both the fetal head and hand are applied to the cervix with fingers visible through the cervical os. What is that? This patient is presenting with spontaneous labor in the setting of a normal pregnancy. The patient's labor.
مش بتحسب كده يعني.
اه
بقول لك انت ياسين معاه صح ياسين؟
ممكن عايزها.
Okay, so we gotta, in the beginning, we gotta manually try to replace the fetus. If it didn't work, then cesarean delivery. So you are streaming tomorrow? Yeah, I am. I feel like I need to sleep for like an hour or something. I'll wake up to continue studying. I feel like so tired. Feels so tired. feel like I'm gonna take a break. Take a break and do this block. Sorry. I told you, bro, I have no car. My car broke. I literally just bought this car a month ago, and I got scammed. And the guy's not responding to my text. He's not responding to my calls, anything. It's so sad, actually. I like this car a lot. It's 2009 Honda Accord. Let me show you. Yeah, that's exactly my car. So it turns out like the engine broke because there's something called the head gasket. The head gasket is basically something that carries the antifreeze. Well, it carries a liquid that prevents the engine from overheating. So that gasket was leaking, so my engine overheated and just, it's done. It's over. I paid like $600 something on just the diagnosis. It's so funny. So now I need to like get some money to get a new car. I'm gonna call my friend actually. Let me see.